Hello, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. Today the topic I am going to talk about is called as PGD or PGT, Pre-Implantation Genetic Diagnosis or Pre-Implantation Genetic Test. What is PGD? When PGD is done? What are the types of PGD? How PGD is done? What are the results of PGD? What are the problems of PGD? What is the cost of PGD and how does PGD help us? We'll discuss all these things in today's video. So let's start. In a typical IVF cycle, the embryologist decides whether the embryo is good or bad by looking at the picture of embryo. That is called as grading of embryo. If anybody has undergone an IVF, they'll say grade A, grade B, what type of grade. That is basically looking at the morphological picture of embryo. That usually tells about the implantation potential of an embryo, but usually it is not the case in most of the cases. Recently, in last few years, about 8, 10, 15 years, this new test, pre-implantation genetic diagnosis, has come, which tells us about the genetic profile of embryo, which tells us about additional information about the reproductive potential of the embryo implantation. And in most of the cases, the genetic errors, the chromosomal errors in the embryos are most important cause of implantation failure. They are most important cause of pregnancy failure. So PGT is a test which must ideally be integrated in an IVF setting for most, if not all the cases. When should we do a PGT? Many times when the patients come to me with an IVF failure, or when I refer some patient for an IVF and the IVF fails, the first question in the mind of patient is, sir, why did my IVF fail? The embryos were good as the embryologist had said. Endometrium was good. So what can be the possible cause? And we tend to scratch our heads as to what can be the possible cause of this IVF failure. Like I said in my previous videos, IVF is a seed and soil. Seed is the embryo and soil is the endometrium. So for a good IVF outcome, you need to have a good quality seed and a good quality soil. That means a good quality embryo and a good quality endometrium. Whenever the IVF fails, for soil we do a test called as ERA, that is endometrial receptivity array, which tells us about the genetics and the chromosomes of at various point of times, whether the endometrium is receptive, pre-receptive or post-receptive. And likewise, for embryos, we get to do a test called as PGT to know the genetic profile, to know the implantation potential of that embryo, because like I said, aneuploidy is one of the most commonest cause of IVF failure and for that matter, miscarriage. So that is why PGT needs to be done. Aneuploidy can be of three types. It can be an extra chromosome, that is a trisomy. It can be a loss of one chromosome, that is a monosomy. Or it can be an extra set of chromosomes which is added, that is a triploidy. Most of the embryos of trisomy can implant, but they lead to various chromosomal malformations. So we have to diagnose those kinds of embryos. Aneuploidy, like I said, is the cause of the most of the implantation pregnancy failures, especially in women with advanced maternal age. Now, what do we call this advanced maternal age? Any female more than 35 is called as advanced maternal age, and for that matter, I would still go to recommend any female more than 30 should get a PGT-A. What is this PGT-A? I'll come back to it later in the video. It is also done for some of the patients who have got a family history of a genetic disease like a thalassemia, like a sickle cell anemia, hemophilia, Duchenne muscular dystrophy. In all these cases, the PGT-A has to be done. What does this PGT-A do? So for example, I did IVF of one patient. We got 7 embryos. In all those individual embryos, we will do PGT of each embryo to rule out the specific problem which is there in the problem family. Suppose a family history of Duchenne muscular dystrophy or a spinal muscular dystrophy is there, atrophy is there. We will check with fish for the same test, and if that only the genetically normal embryos are kept and the rest of the embryos which have that problem, they are discarded, so that we are trying to prevent that genetic disease in the child in future. There can be various genetic disorders like autosomal dominant, autosomal recessive, X-linked recessive like Duchenne muscular dystrophy, like Fragile X syndrome, like hemophilia A and B, autosomal dominant disorders like myotonic dystrophy, Huntington's disease, autosomal recessive disorders like this thalassemia, sickle cell anemia, Tay-Sachs disease, sickle cell cystic fibrosis. All these diseases can be diagnosed and they are very, very important to be prevented. which type of, there are three types of PGT, and now I cannot decide, patient cannot decide that I need this type of PGT. There are three types of PGT-A. One is PGT-A, that means Preimplantation Genetic Diagnosis for testing aneuploidy. One is PGT-M, that is testing for the monogenic disorders. And one is PGT-SR. PGT-SR means it tests for the structural rearrangement in the chromosomes, whether it is a balanced translocation, Robertsonian translocation, unbalanced translocation. I'll come back to each and everything. Most common PGT which we most commonly do in our infertility and IVF practice is PGT-A. It is recommended for previous patients of IVF failure, for females who have advanced maternal age, for females who have long-term unexplained infertility, for females who have recurrent implantation failure, for females who have history of recurrent miscarriages. It is also done for females who have got a severe male factor infertility. It is also done for unexplained infertility, because we presume if all the factors are normal, if the fallopian tubes are normal, if the male factors is normal, if endometrium is normal, there is no uterine factor, then in most of the cases, this is most likely to be a chromosomal factor or a aneuploidy. So if we detect any embryo which is aneuploid, which is not normal, then those embryos we have to discard and we have to transfer only euploid and normal embryos. So PGT-A basically can increase the chances of pregnancy in an IVF with decreased attempts. It decreases the disappointment of multiple IVF failures. It decreases the chances of miscarriages. It decreases the chances of cycle cancellation, and it also decreases the cumulative cost of the patient by reducing the unnecessary transfers of aneuploid or abnormal embryos, which are either not going to implant or which are going to cause more chances of pregnancy failure or miscarriages. Another type of PGT is called as PGT for monogenic disease, that is the single chromosomal disorders. Like I said, there are various single genes diseases. It can be autosomal dominant, it can be autosomal recessive, it can be X-linked recessive. Autosomal dominant means, I have again discussed, like cystic fibrosis, Tay-Sachs disease, beta thalassemia, sickle cell anemia. It can be Huntington's disease, it can be myotonic dystrophy, and X-linked disorders like hemophilia A, hemophilia B. It can also be done for Duchenne muscular dystrophy. Now this X-linked disorder is very, very important. Their X-linked recessive disorder means the female is a carrier. That means female has the gene, but female is not symptomatic. Only males carry the disease. So if there is a history of hemophilia A or B, or if there is a history of Duchenne muscular dystrophy, then in those diseases we do PGT-M for this particular disease, and we take the embryos which have got this chromosome for this particular disease out, and we transfer only normal embryos so that we can prevent this disease from happening further. This PGT-M is also done for hereditary cancer syndromes like hereditary ovarian and breast cancer or Lynch syndrome. In those cases, we specially test for these disorders. And one very important factor, severe sibling. Suppose other child has got, the first child has got thalassemia or sickle cell anemia, and parents, there is no other cure at this point of time other than a HLA match bone marrow transplantation, which is very difficult to get. So what the parents can plan in next child, and by doing an IVF, when we generate the embryos, we match, there is a HLA matched embryo is taken, and in that embryo the particular beta thalassemia or sickle cell anemia is ruled out, and the normal embryos are transferred. The moment that child is born, the umbilical cord cells or the stem cells of that child are collected, they are harvested, and they are then transplanted at an opportune time instead of bone marrow to the affected child. That child is called as a severe sibling, and many such cases have been there in recent past, and this is another very, very good and a best application of a PGT-M. Next comes is PGT-SR, that means PGT for the chromosomal structural rearrangement. It can be a translocation, it can be an inversion. In all those cases, it can be, like I said, they can be cause of a repeated miscarriages. It diagnoses Robertsonian translocation, it diagnoses balanced translocation, it diagnoses unbalanced translocation. We cannot 100% diagnose all the translocations, but at least whatever amount of translocation or inversions we can diagnose, we take those embryos out and we transfer the normal embryos. Even after transferring the normal embryo, the routine anomaly prevention protocols like double marker, like NIPT or amniocentesis SOS have to be done in all the cases. So this was about the types of PGT. When do we need PGT? Now how this PGT is done? There are two steps. One is an embryonic biopsy and another is a genetic assessment. Embryonic biopsy is done at day 6 embryo. Few 5 to 6 cells of trophoectoderm are taken. Mind you, while taking this trophoectoderm biopsy, only the outer cell, that is trophoectoderm, is disturbed. The inner cell mass by which the baby is going to be formed is not disturbed, and only trophoectoderm, which is going to form placenta, is disturbed, and even out of that only 5 to 6 cells are taken. So there is no chances of harming the blastocyst or the further baby in this procedure. There, by the laser, a hole is made in the zona pellucida. By that hole, trophoectoderm protrudes out, and from that few cells are taken, and immediately after that the embryo is frozen. Once that few 5 to 6 cells are taken, they are sent for the genetic analysis. Genetic analysis is done by two measures. It can be done by PCR or it can be done by FISH. PCR, that is polymerase chain reaction, is used for the application of genetic material. It is usually done for single chromosome disorders, monogenic diseases, and FISH is usually done for diagnosing the aneuploidy screening. The techniques of aneuploidy screening, there are two techniques of aneuploidy screening. In FISH, according to that particular chromosomes, the complementary base pairs are made, and from that the fluorescent signals are detected, and that's how they detect whether that particular disease is there or not. Recently, this is an invasive technique. The non-invasive techniques have come. They use two techniques basically. One is the blastocell fluid, or other is the spent blastocyst culture medium. In that, whatever amount of DNA is there, that is extracted and that is taken for the analysis. The quantity of DNA which we get is not much in that non-invasive medium. The studies are going on, but still, if the gold standard is a biopsy and invasive method that has a success rate of 96%, the non-invasive methods currently have a success of 86%. Kuznetsova combined both these methods, blastocell fluid and blastocell spent culture medium, and that gives a relatively good chance of detecting the DNA and thereby doing a PCR or FISH out of that. Recently, NGS, next generation sequencing, or CGH, complementary genetic hybridization techniques have come. They are still better than FISH. They diagnose various mosaics patterns. A high level mosaic or a low level mosaic. A high level mosaic means there are more chances of abnormal chromosomes and less normal chromosomes. A high level mosaic, if it is there, if it is more than 40% mosaicism, then the chances of implantation potential are less. If there is a low level mosaicism, then there are relatively better chances of implantation. Now the report of PGT-A comes in about 7 to 10 days. If it is a specific complex genetic condition, then it might take 2 to 3 weeks, but in most of the cases 7 to 10 days. Usually per embryo, PGT costs about 10 to 15,000 bucks, but that is still better than the chances of an embryo transfer which fails or which results in an miscarriage. The PGT-A report, the geneticist usually gives report in 5 columns. Either it is a euploid embryo, that means good to transfer. Aneuploid embryo, that means abnormal, it should not be transferred. Or it can be a mosaic pattern. Mosaic means normal and abnormal embryo chromosomes are mixed. Again, I'll come to the conundrum which we face when we get a mosaic pattern report. It can be an inconclusive report. If there is an inconclusive report, that means we have to repeat the embryonic biopsy. Or it can be a misinterpretation. Now, misinterpretation is very, very important. Because we take only 5 to 6 cells of trophoectoderm, it does not necessarily mean that it may definitely be a normal or definitely be an abnormal. So that sometimes puts us into a bind. Now, PGT-A, the more advanced age is, the more if we do PGT-A, then we increase the chances of success. The percentage-wise chances of success I'll put it into the description. But they say if female has undergone PGT-A of all the embryos, then the chances of having a successful pregnancy past 20 weeks in 3 cumulative transfers is about 95%. I'm repeating myself. If we do PGT-A of all the embryos And if we do a single embryo transfer of any euploid embryo, the chances of pregnancy going past 20 weeks in cumulative 3 transfers is more than 95%. 3 consecutive frozen embryo transfer. This is an excellent rate of success. So, by doing PGT-A, we increase the chances of implantation, we decrease the number of attempts, we decrease the chances of miscarriage, we also improve the pregnancy outcome, that is a healthy baby and a healthy mother. One thing is for sure, that a absolute normal embryo by PGT-A does not guarantee that pregnant child would be absolutely normal of all the chromosomal anomalies. Because we are taking only 5 to 6 cells, again I am repeating, because we are taking 5 to 6 cells and we have to take only 5 to 6 cells because we do not want to disturb the placental formation much. We also don't want to disturb the inner cell mass which is going to form the baby. So that may sometimes be misrepresentative of the sample. So all the antenatal tests like a good anti-scan by a fetal medicine specialist, a good NIPT or an amniocentesis as a, when the case suggests, should be done to rule out all the traditional testing of aneuploidy should be done. So the conundrum which we face, mosaic embryos, whether to transfer or not, they've done one research and they have found that of all, because of this next generation sequencing which we are mostly doing nowadays to find out the mosaic embryo, to find out the chromosomal anomalies, as high as 20%, that means 1 in 5 embryos would be mosaic. Usually we should not transfer the mosaic embryos if we have got euploid embryos. But if we do not have the euploid embryos, then depending upon the gradation of mosaic, if it is less than 40% mosaic, then we can transfer. And the research has found that in about 8 to 9% of cases in which mosaic embryos were found, a full-term healthy child was born. So the recommendation says, if we have got euploid embryos, then we need to transfer only euploid embryos. But if we have got mosaic embryos and the mosaicism is less than 40%, then we can transfer those mosaic embryos. Are there any risk of doing PGT? In about 5% cases, they say because this is an invasive procedure, there might be the embryonic damage, the embryos might be destroyed by doing PGT. Or it might be inaccurate. So all the cases of a PGT have to be confirmed by doing routine NIPT or amniocentesis. This is very, very important. This is extremely important. How, suppose I have done a PGT and I have got 4 euploid embryos. So should I transfer 2 embryos? Now see, in past 20-30 years, earlier people used to transfer 2 embryos, 3 embryos. If we are doing PGT, then only single embryo transfer, irrespective of maternal age, whether mother is 35, 37, 40, only a single embryo should be transferred. And if we do 3 such consecutive cycles, if there is no uterine factor, no endometrial factor, then in 3 consecutive cycles, there is 95% chance that female should conceive. So, in conclusion, PGT is a diagnostic tool to do a genetic profiling of the embryos. We discard genetically abnormal embryos. By discarding these genetically abnormal embryos, we are transferring only good euploid embryos which have got an excellent implantation potential. Thereby, we decrease the number of attempts at IVF. We reduce the disappointment which comes with multiple IVF cycles. We also decrease the chances of miscarriage which occurs as a result of transferring chromosomally abnormal embryos. We decreases multiple miscarriage chances, and we also prevent transfer of any genetic disorder. Having said that, PGT is not 100% accurate. The technologies are still evolving. Even after transferring of an euploid embryo, we need to do all the chromosomal screening things which we normally do in an antenatal patient, like a good anti-scan, like NIPT, double marker or amniocentesis, whichever is applicable to the patient. I would say in conclusion, PGT should be routinely incorporated for all the patients of IVF to ensure best chances of result with minimal possible outcomes, and thereby over a period of time decreasing the cumulative cost of the patient. Hope you like the video. If you have any questions, please comment in the comment section. Please share the video, subscribe to our channel and like the video. Thank you. Namaskar.